Okay, this is part 2 of the ultrasound basics, and we will go through a little bit more detail on a few of the ways to improve your ultrasound skills, as well as a few things about Doppler and basic physics. So first, remember, critical care ultrasound is a new discipline. It's not the same as radiology, cardiology, or even emergency medicine, although a lot of these applications that we're going to be learning through the curriculum can be used in all these other areas. They're meant for the crashing patient, either hypotension or hypoxia. The new applications are adapted to use in critical care and have a point of care focus with point of care questions. As you see throughout the didactic lectures, they will mostly start with focused questions, and that is probably the most important thing for you to realize, is that a lot of this ultrasound that we will be doing is only aimed to answer focused questions that will help you at the bedside to help your patient for patient care. Remember, critical care ultrasound is a real-time discipline, and so usually must be used to help make decisions at the bedside and not for long-term patient care planning. Throughout the curriculum, you'll see many different signs that we talk about. Most of these you probably have never heard of in your life, but as we further progress, you will know what all these things mean. Most of the curriculum is based off of these couple of these books. One of them is from Emergency Medicine by Vicki Noble, Emergency and Critical Care Ultrasound. Daniel Lichtenstein with Whole Body Ultrasound in the Critically Ill, and Levitov's book on critical care ultrasonography. I suggest all these books are very good and very informative, and if you're interested in the curriculum, you should possibly get these books or read through them as we go through all the different topics. So what's the best way to learn IC ultrasound? It's kind of similar to how you learn physical exam skills. Most early learners try to learn everything all at once, and I know they get overwhelmed. Pretty much, I think after doing this a few years, the best way is to pick one application or even part of an application, like how to evaluate the lung for pneumothorax or how to evaluate for left ventricular function, and then focus only on that. Find a bunch of normals. Then when you hear of abnormal ones, go and try to find that for yourself. Just like we don't suddenly become intensivist over a span of like 1-2 day course, you don't suddenly become a sonographer over a 2-day course. Also, remember, you're trying to use the ultrasound to help make decisions, and so the better intensivist you become, or the better emergency medicine physician, the better anesthesiologist, the better medicine doctor, the better sonographer you're going to become, because it's going to improve your skill set, just like a physical exam. If you remember when you were in medical school or earlier, you would learn about the basic physical exam of the abdomen. Then you would try to go find a couple of patients that had cirrhosis. And I suggest ultrasound is the same way, where once you do a lot of normals, then actively go out and look for people who you know have abnormals. That way, when you have your patient that is not diagnosed, you will be able to identify that not for the first time, but after you have seen some other abnormals. So again, the first tip is, once you learn to interpret, for instance, with pneumothorax, like lung sliding, in normal patients, find a patient with a confirmed pneumothorax and try to find the signs that we talk about, or the absent lung sliding. Now the second step would be, you have a patient that you search for actually absence of lung sliding or stratosphere sign in a patient with an acute problem, but continue to manage it as you normally would. For instance, get an x-ray, get a CAT scan, whatever you would have done in the past. So the goal is to get to the third step, where now you're facing the same patient, but now you have no time for the CAT scan, and you find no lung sliding, or you find lung sliding and you determine that a pneumothorax is not present, and you don't put a chest tube in. And it drives your thought process in another direction. Or you may find a pulmonary embolism, and you're unable to take the patient to CAT scan, and you go ahead and make the decision to put heparin on the patient. Or you can learn wild ultrasound, which sounds funny, but It really is what a lot of people learn. You work a night shift on a crashing patient. You use ultrasound knowing your own limitations. You barely remember one or two lectures about a specific topic, and you get better and better at ultrasound. It's not wrong to learn that way, but that's not the way we want to learn here. We want to learn through a structured curriculum. So first, let's talk a little bit about the ultrasound equipment. New machines don't actually equal better machines. They're not specific. Most of them are not specifically required for designed for critical care. Small machines are not necessarily more convenient, although we do want smaller machines. We need ultrasounds dedicated to critical care, which are small in width, to go between the ventilator, the IV poles that I talked about in the last lecture. We need them compact design with minimal nooks to clean, so we're not spreading infections. We probably need ones with short startup time. We want ones where you press on button and they're ready to go in 5 to 10 seconds. We probably really only need 1 or 2 probes. Even though most people think we don't need Doppler, Doppler may be somewhat beneficial. So you might ask yourself, when you first start this, who should get ultrasound? In France, a few of the hospitals, they do ultrasound on everyone at their first admission to the ICU and then subsequent specific problems. They said they've been able to catch multiple issues like smaller veins or larger veins or heart failure that they did not know about. I think in ICU or in the emergency setting, folks who are hypotensive or hypoxic probably benefit the most. There are a few algorithms developed to evaluate these, and we'll go through them throughout the curriculum. But on the horizon, I think there's more applications such as the patient with a fever of unknown origin, cardiac arrest, oligoanuria, specific ones in sepsis, ARDS, or difficult airway, weaning from mechanical ventilation. I think all of these are problems that can be solved, or at least improved diagnosis through the use of ultrasound. This is just a table in France where they use ultrasound for all the different areas, looking at the lungs, the heart, the head, the abdomen, and then they kind of come up with a plan. I know nobody likes ultrasound physics, so we're only going to do what I think is the most important parts of them. Obviously, ultrasound is a very technologically oriented machine. If you're interested in it, you can go learn it on your own, but most of the stuff I talk to you right now is going to be most of the physics that you'll learn throughout this curriculum. So just a few basic definitions. There's amplitude, velocity, we're going to go through frequency, wavelength, attenuation, the different types of artifacts, reflection, refraction, scattering, and acoustic power. So first, amplitude. It's what determines the echoic of the nature of the picture you see. So essentially the hyperechoic or hypoechoic. It equals the peak pressure of the wave for the physics part of it, or the loudness of the sound actually, and it correlates with the intensity of the returning echo. So again, remember all the echoics. Anechoic means black, and hyperechoic is usually white. Air and bone are hyperechoic. Fat, blood, and fluid are anechoic and have less attenuation. The most attenuation something has is air or bone. The least attenuation is blood or fluid. And it determines how much sound can get transmitted through. The velocity is the speed of the wave. In soft tissue, it's about 1540 meters per second. Ultrasound can use this to determine the depth of the structure, like sonar used in submarines. So essentially, when you change the depth on the machine is using the velocity of the wave through whatever medium you're using to help you determine that depth. We just press the depth up and down button. The frequency is the number of waves per cycle, or cycles per second. This is important actually because a lot of times people will tell you this is 12 megahertz probe, or a 10 megahertz probe, or a 5 megahertz probe. So essentially what's important for you to know is that the higher the frequency of the probe, the more resolution there is, and the less penetration or the less wavelength. So essentially on the right you see the higher frequency, which means more resolution, less penetration. You can think of this as like a vascular probe. So when you're looking at vessel structures in the neck, you're going to have a better resolution with the vascular probe, which is anywhere from 8 to 12 megahertz, and less penetration. So the depth that you can use is probably at most like 5 to 8 centimeters. Whereas if you use probes with low frequency, such as the abdomen probe, you get less resolution. Obviously you don't see as much detail, but you can penetrate more depth. So you see like 15 or 20 centimeters of depth. The wavelength is the distance the wave travels in one cycle. That's all I'm going to say about that one. As I mentioned earlier, attenuation is the progressive weakening of sound wave through a medium. So many factors affect this, like the type of medium, the number of interfaces. For instance, if you're going through fat, then fluid, then fat again, then the next fluid will probably not be as easy to see. Air is a strong reflector and does not really transmit. Bone has high attenuation. Fat or fluid would be the least attenuation. Some other definitions are like reflection, which is redirection of part of the sound wave back to the source. Refraction is redirection of part of the sound wave as it crosses different media. Scattering is when the sound beam encounters a smaller or irregular shape. Absorption is when acoustic energy of the sound wave is contained within the medium. And resolution, which is the main one that we're worried about, is ultrasound machines' ability to discriminate between two close objects. And so something with high resolution, you'll be able to see a much better picture than low resolution. Acoustic power is not as important to us. It's the energy that leaves the transducer. There's a thing called ALARA principle, A-L-A-R-A principle, as low as reasonably acceptable. And the thought is that you should always be using this kind of principle when you're using ultrasound. Therapeutic ultrasound is a whole new lecture. We don't really do any discussion, or none of the curriculum talks about therapeutic ultrasound, which is, for instance, breaking up kidney stones and things like that. It's a field all in itself, and we don't talk anything really about that. A few points I want to talk about Doppler. The Doppler mode on the machine is used to detect speed, presence of flow, and direction of flow. Generally, a sound that moves away from an observer, the frequency will decrease, kind of what you hear with police sirens. A positive Doppler shift means blood flowing towards the probe. A Doppler is most accurate when the angle of the beam is parallel to the blood flow, or to the flow. For instance, when we talk about the apical heart view, you'll see that the probe is parallel to the flow. And because of that, you will actually have better, more accurate numbers. Red means towards the probe, blue means away. Remember, red does not mean artery, and blue does not mean vein. And last, velocity scale needs to be set as low if you're looking for a low velocity, like veins. Use the gain buttons within the color Doppler mode, and I'm going to show you that on the next screen. So for instance, once you press the color Doppler mode, you're going to see a screen that looks kind of like this. If you put your probe, just aim it towards the air, you're going to see something like this. Now what you see here is me changing the color, usually the same buttons that you see for the gain. You can turn it up and down, or usually turning the knob. And what you see, if you turn it all the way to the right, is all this scattered kind of red and blue dots. What you want it to be is kind of where you barely see some red and blue dots. You don't want it to be totally black, and you don't want it to be totally bright, where even moving your hand causes some kind of change in flow and will be too sensitive. So you want it somewhere right in between. Here you see a color Doppler image of a vein and an artery. Remember, blue does not mean vein, and red does not mean artery. It really just depends on how your probe is angled. If you're in the neck and you're looking at the artery, carotid artery, and internal jugular vein combo, if you angle your probe cephalad towards the brain, the artery should be blue in color because blood is going towards the brain, and the vein should be red because the blood from the brain is flowing out towards the heart. So as you see in that case, red does not mean artery. On this next slide, you actually see me fanning the probe from towards the head and then down towards the heart. So at first you see that the internal jugular vein is blue because blood is going away from the probe. So in that case, my probe would be pointing in the neck towards the heart because the vein is going away. But as I move the probe towards the head, not actually move, just angle it towards the brain, you can see that the vein changes from blue to red because now the venous blood is coming towards my probe. A better example is here. This is an apical view of the heart. On the top where you see my probe is, that is where the probe actually is. You see the mitral valve, which separates the left atrium and the left ventricle. The red that you see is actually flow of blood towards the probe. So you can see blood flows from the left atrium to the left ventricle through the mitral valve, and you see that as orange or reddish color. But you also see blue color to the left of it. That's actually blood that's going out of the left ventricle into the aorta. That's the aortic outflow tract. So in this image you can see red and blue of a normal patient. Now if you were to see a lot of blue on the left atrium side, that would indicate to you some mitral regurg because blood is going away from the left ventricle. So the last slide is here. Again, how do you get better at learning ultrasound? After these first two basic ultrasound lectures, remember, throughout this curriculum you're going to be reading a lot of literature. It's very important that you do not skip over the reading part. That is where you will gain a lot of your base knowledge. Remember, your own familiarity with your own field, for instance, if you're a resident in emergency medicine or if you're a fellow in critical care, as you learn more about your field, you will learn more about ultrasound. And again, just like anything else, practice, 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 just like any other procedure. Just like any procedure, like the first central line, or 10 central lines, or 100 central lines, or 1,000. With each 10, 100,000, you get better at that procedure. Same thing with each of these ultrasound applications. As you do them, you will get better. So the point is to keep doing them, even if your initial images are not great. And that's it.